All right, next up we're going to talk about open fractures. We're developing a surgical emergency response team. We've had 2 instances recently with people struck by trains, and that has triggered this whole thought. We initially started this before COVID, and then COVID happened. We had to put it on the back burner. But we are partnering with our trauma surgeons at Kennestone to develop a CERT protocol to where we can go out and perform field amputations. Basically, the medical director or an ER physician will administer sedation, and the trauma surgeon will perform an amputation if necessary.
And this is 24/7. They'll be on call. So
correct.
Okay.
We're hoping to have that open or up by middle of next year. But one of the requirements is that we carry antibiotics, because patients that get amputations in the field need antibiotics. And we were looking at ceftriaxone. And we decided to just basically adopt it for all open fractures. There's been a big push by our orthopedic trauma people at Kennestone to give this in the field, because the quicker you give it, the less likely they are to have any type of infectious complications with it.
Well, that's good.
Normally in the ER we use cefazolin or Ancef for most of our non-complicated open fractures, but just to make it easier, Rosefin is fairly cheap, so we're just going to put that on all the trucks and use that. Maybe a little overkill for it, but there's really no harm with it.
Perfect. And we'll show you guys how to mix that here in a little bit. And so all the ALS units will be getting Rosefin.
And there's really no contraindication for it except for allergies. That's about the only time that you would not give it for somebody. So if you have somebody that has a laceration over a deformity or swelling that you think may be broken, there's really no harm if you start an IV and give them some Rosefin.
Gotcha.
The studies show that quicker antibiotics cause less infections. Some of these infections are very severe and require amputation, or they'll have osteomyelitis and they have 6 months of antibiotic therapy. As I mentioned, Ancef is normally what we give, but Rosefin in a combination with vancomycin is basically given for more complicated or femur fractures.
Gotcha.
The vancomycin component we're not going to worry about, because the ER will take care of that when they get there. So we're going to make it simple: Rosefin for all, or ceftriaxone, and then vancomycin can be given in the ER.
Perfect.
So the indications: any suspected fracture, like I said, laceration overlying a deformity or swelling. Basically, you have to have, expose the area to look at it. And this is one of the things that when Cobb Fire gets on scene and dresses a laceration from a fracture or splints it, you may be the only person that looks at it between the patient and the physician. Because EMS gets on scene, or not EMS, but the transport truck gets on scene, they're not going to take it down and look at it. The triage nurse usually doesn't take it down and look at it. It's usually the physician that does, and so this will help with some of the delay by giving it earlier. As I mentioned, there's no risk other than allergies. If somebody does have an allergy to cephalosporins, so Rosefin specifically, if they have it to Ceftin, Ancef, any of those, then basically they wouldn't get this. If they have a high-grade penicillin allergy, I'm not talking about just a simple rash, I'm not talking about, they get nausea with it, I'm talking about somebody that has true-on anaphylaxis, then they probably shouldn't get this.
Gotcha.
And then they'll receive clindamycin when they get in the ER, which is our alternative, as well as Trianam.
Gotcha.
It's pretty simple: 1 gram IV, can also give it IO. You can give it IM, but it's not as effective, so I would probably do IV and IO only for an open fracture.
Yeah, and I know IM, it actually is a lot more fluid we're giving in. So
right.
That's one of the downsides also we were looking at.
Never had it, but I hear it's pretty painful.
So Doc, now we're going to do the Rosefin. Once again, all the ALS units, because we're going towards that CERT, which is going to be awesome. I know that protocol will be coming out to figure out who's picking up the trauma surgeons at the hospital.
Right.
So, and then of course, hopefully you'll be there on scene with us that first good
Hopefully
time.
so.
But we're going to have a Rosefin. And so like the doc said, we're going to do 1 gram IV over 2 minutes. The biggest thing is how to mix this. The simplistic way is to take a 10 cc flush and a blunt needle. So you're going to take your 10 cc flush, you're going to put your blunt needle on, pop the top, and then you're going to push 10 cc's in, And I know in the hospital when they do it, sometimes they just leave it on there. But you can put the 10 in, and then all we're going to do
Little
is now-
explosion.
Yeah, a little explosion, and just start mixing it up. You can let it sit while they're getting IVs and everything else, but it takes about 1 or 2 minutes to actually mix. And then once it's actually mixed up, IV's going, we're going to give it slow IV push. And as you can see here, particulates are almost completely mixed. It doesn't take too long. The easiest way is a 10 cc flush, a blunt needle, put the whole 10 cc's in, and now you've reconstituted it.
One thing to keep in mind with Rocephin is that it's incompatible with lactated ringers. We personally don't carry LR, but if Metro or Puckett carries it and they start LR, you can't give Rocephin through that. So you need to disconnect the IV tubing, flush it with 10 milliliters, then administer the Rocephin, then flush it with saline again, because it will cause some calcium precipitates.
Gotcha.